And just for disclosure of funding for our research, our group receives grant funding from the government through the National Institute of Health and various industry partners that you could see. Next slide, please. I'm going to start off with these two studies that have made headlines over the last 2 weeks, especially here in the United States. These two studies claim that the combination of hydroxychloroquine and azithromycin is a magic cure for COVID-19. Neither study, which actually came from the same team in France, was randomized or placebo-controlled. The first had 36 patients and the second had 80 patients. Shortly thereafter, around the United States, patients admitted to the hospital for COVID-19 were started on this regimen, even with very little evidence. Next slide. And this narrative reminds me of the most cited study in the history of medical literature. And this is the paper that has been cited most numerous times. In 2001, Griet van den Beer and her colleagues in Belgium published their study on intensive insulin therapy in the New England Journal of Medicine. The paper, as I mentioned, is now one of the most cited publication in the history of medicine. And subsequently, ICUs and hospitals around the world adopted some protocol for glycemic control. And soon a $1 billion industry and workforce around glucose monitoring in hospitals and skilled nursing facilities was born. But there is something incredibly wrong with how this unfolded. The research was performed in an ICU in Belgium, and its findings, as we find out much later, is not generalizable to the world. Indeed, the way that medicine is now, the way medicine is being practiced is based on research performed in only a handful of countries. Medical knowledge is generated and maintained by an exclusive club of experts and then distributed to the rest of the world. For low-income countries, research is deemed a luxury that they could not simply afford. So they practice medicine and provide tests and treatments that may not work for, or worse, may be harmful to the local population. Next slide, please. Hundreds of clinical trials are underway investigating every facet of care of COVID-19 patients, as if care practiced before the pandemic is based on randomized controlled studies. In reality, only a minority of practice guidelines is based on prospective randomized controlled trials, or RCTs. In the intensive care unit where I work, that fraction is about 9%. The specialty that has the highest proportion of RCT-based practice is cardiology at 10%. Oncology is at 6%, and the rest of medicine is at 5% or less. Next slide, please. But even when randomized controlled trials exist, there is a suspicion in the research community that they all produce biased results to a certain degree. As we know, clinical trials involve complex processes, from randomization to blinding to controlling to implementing treatments and then to monitoring participants. And this requires many decisions at different steps that bring their own assumptions and degree of bias to the results. Next slide, please. In 2012, the Institute of Medicine, which is now called the National Academy of Medicine, commissioned a group of experts to evaluate more than 300 clinical practice guidelines in the United States. In a report that followed the review, they concluded that for many clinical domains, high-quality evidence is lacking or even non-existent, and often practice guidelines rely on low-quality evidence or expert opinion. Next slide. In the United Kingdom, the National Institute of Health and Care Excellence and the British Medical Journal partnered and combed through thousands of treatments that are administered to British patients. What they found is that 50% of current treatments have unknown effectiveness. 10% have been found to be ineffective or even harmful and yet are in use. and only about 40% have some evidence of effectiveness, not necessarily strong, but at least some evidence of effectiveness nonetheless. Next slide. And indeed, when current standard of care is put to the test, 40% of the time, there is discontinuation of practice. Vinay Prasad and company looked at 363 papers published in the New England Journal of Medicine between 2001 to 2010 that evaluated an existing medical practice. In 40% of the studies, they found that the practice was ineffective or even harmful, leading to what we call as medical reversal. The authors opine that it seems that the medical community does not gather enough evidence before a practice becomes commonplace. And for lack of a better alternative, this has become the norm since the pandemic began. Next slide. Perhaps one of the biggest problems in healthcare that I alluded to earlier is the historic omission in research of certain groups, including women and underserved population, that has skewed the generation of medical knowledge. And there is a reason to believe that the pandemic will make this worse. Next slide. The Framingham study, for example, that produced the cardiovascular risk score to calculate the probability of heart attacks and strokes, sampled from an overwhelmingly white male population in one of the communities here in the United States, in Framingham, Massachusetts. Not surprisingly, the score is not consistently accurate across the board. For example, the predicted risk of a cardiovascular event was 20% lower among Blacks when compared to the actual number of events. Next slide. Doctors not only operate with imperfect knowledge, in addition, they also operate with unconscious biases that lead to medical errors. This is a graph showing the incidence of preventable deaths in healthcare across different countries. Preventable deaths are defined as deaths that arise from adverse drug events, hospital-acquired infections, and other treatment injuries. There are legitimate concerns that this might increase as health systems are stressed and as frontline workers are overworked. Next slide. And even before the pandemic, upward of 12 million Americans see a physician and come away with the wrong diagnosis every year. Judgment errors account for 86% of these mistakes. But the rate of medical errors varies by race and gender. If you're having a stroke, there's about a 9% chance that you will be misdiagnosed in the emergency room here in the US. Being a woman raises that risk by 30%. And then there's race. For people who have severe depression, African Americans are 4 to 9 times more likely to be misdiagnosed with schizophrenia compared to white Americans presenting with the same cluster of symptoms and are prescribed the wrong medications. Next slide. My first key message is that judgment errors in decision-making, including those that arise from biases, are at the heart of medical errors and health disparities. Next slide. And this problem is not true just in high-income countries. This is a ubiquitous problem even in low-income countries. One of the very first paper looking at quality of care in low-income countries was published in 2012 in the British Medical Journal. In the paper, the authors reviewed more than 15,000 patient records, which were randomly sampled and analyzed from 26 hospitals in 8 countries. Next slide. The authors hypothesized that the poor quality of care in low-income countries is probably due to lack of medications or access to specialist care or laboratory services and other technology. But what they found was that after reviewing the charts, the 2 biggest contributors to poor quality of care are treatment errors and diagnostic errors. Next slide. Another report, this one coming from the World Health Organization, looked at medication use in primary care in developing and transitional countries. The authors reviewed 679 studies from about 97 countries that were published between 1990 and 2006. What they found was that in more than 50% of the time, medicines were prescribed, dispensed, or sold inappropriately, and half of all patients failed to take the medications correctly. Less than 30% of patients were treated according to some existing clinical guidelines. These two reports that I just mentioned highlight the reason why data and learning have to be at the front and center of healthcare. Next slide. So just to repeat that sentence because it's really important, now more than ever, data and learning have to be at the front and center of healthcare. Next slide. So I represent a group called MIT Critical Data. This is led by our laboratory, the Laboratory for Computational Physiology. And our mission statement is that data sharing and collaborative learning are really the best medicine for population health. This consortium consists of healthcare practitioners, computer scientists, engineers, and social scientists who believe that we need to be constantly learning from the data that we accumulate when we're caring for our patients. We build communities across disciplines to derive knowledge from data routinely collected in the process of care in order to understand health and disease better and in the local context. Next slide. So these are 3 data sets that our team has put together and made available to the entire research community. The data set on the upper left hand is called MIMIC. It stands for Medical Information Mart for Intensive Care. And it contains all the data collected from patients admitted to the hospital where I work at, Beth Israel Deaconess Medical Center, admitted to the intensive care units from 2002 onwards. The current version has about 50,000 ICU admissions and would have data until 2012. The next version should be released pretty soon, and that will include data up until 2018. And when I say data, I mean all the data, all the vital signs, blood pressure, heart rate, taken every 5 minutes or 15 minutes or every hour. All the medications that are administered are timestamped. All the labs that are collected will also be there. You would also find waveforms that are captured in the bedside monitor, and you would have the notes written by the nurses, the doctors, the pharmacists, the social workers. And this all have been de-identified and made available to the research community. Even just since 2016, for the current version of MIMIC, there have been close to 1,000 publications and conference proceedings highlighting the value of machine learning on health-related data. The one on the upper right-hand side was the database that was mentioned by Saeed earlier. This is the EICU Collaborative Research Database. This time, the data comes from more than 200 hospitals in the United States. It has the same resolution as MIMIC, but without the notes and without the waveforms. And finally, the data set at the bottom of the page is called MIMIC Chest X-ray. And this has the actual chest X-ray obtained from the patient that is linked with the radiologist report. So it's a good database for computer vision. And the current version has more than 350,000 images that have been read by a radiologist. Next slide. We are also invested in the training of the next generation of clinicians and computer scientists and engineers. In 2016, we published a textbook called Secondary Analysis of Electronic Health Records. And in the true spirit of open access, the book is completely free of charge. You could download the book online. Since its publication, it's been downloaded more than 500,000 times around the world. And in the summer of last year, we published a Mandarin version of the book, and a Spanish translation is almost ready to be published. It's a cookbook. Every chapter was written by at least one clinician and at least one computer scientist, so that we make sure that people with different backgrounds are able to understand. And it tells you, how do you start off with choosing the right research question? And then how do you go to a data set with elements coming from an electronic health record, which, as you can imagine, is very noisy because this data set was not developed primarily for research purposes. This is just an exhaust of the digital care, a digital exhaust of the care that the patients received while they are in the hospital or in the clinics. Next slide, please. But the most challenging part of what we do is actually not the technology. The most challenging is changing the culture on the ground. It's removing the silos between the different disciplines who need to work together to fully leverage the value of this data. So we travel around the world, we interface the nurses, the doctors, the pharmacists, the social workers, the medical students, and we connect them with people from the computer science, engineering, as well as the social science disciplines, so that they're able to take advantage of each other's expertise. Next slide. In 2014, we introduced this model that we have termed as the Datathon, as a way to operationalize transdisciplinarity in the field of health data science. Next slide, please. The definition of transdisciplinarity is the intellectual space where the nature of the manifold links among isolated issues can be explored and unveiled, the space where issues are rethought, alternatives considered, and interrelations revealed. Next slide, please. This approach of getting the data into the hands of as many researchers as possible and creating a collaborative ecosystem around the data has produced more than 1,000 publications and conference proceedings from MIMIC and the EICU data set. And I will showcase 3 of them next. This first one was not yet. Back to the previous slide. This was published in Nature Medicine about 1.5 years ago, and it uses reinforcement learning to identify the optimal decision when you are faced with a patient who develops hypotension or low blood pressure in the intensive care unit. There are 3 options when you see hypotension. You could ignore the blood pressure, you could give fluids through the veins, or you could give them a medication that will artificially raise the blood pressure, which we call vasopressors. We don't really have a good guideline for different episodes of hypotension. For the most part, the action is based on the clinical intuition of the clinician who is taking care of the patient. So what we did here is, can we model the different actions taken and reward actions that led to survival of the patient at day 90 days and give a punishment if the patient is dead at day 90. For this particular study, we did not care about other more proximal outcomes. All we cared about is the patient dead or alive at 90 days. But you can repeat this particular methodology and specify whatever outcome you are interested in. And just to remind people, reinforcement learning is the methodology behind the Artificial Intelligence AlphaGo, which beat a human expert in the board game Go. Next slide. You don't need some fancy deep learning methodology to glean important insights from the data. For this particular study, all we did was we looked at all the laboratory tests among the patients admitted to the intensive care unit. For people who have worked in the hospitals, as you know, when you ordered a lab test, you are given by the laboratory a normal reference range. And that reference range is established by sampling 200 healthy patients every 2 years and looking at the central 95% of that particular lab test. And that is presented to the clinicians in the ICU as a normal reference range. But I would argue that doesn't mean anything for my patient who is in the intensive care unit. What could be more relevant is, can we figure out what range maps to a certain outcome. So for this particular study, all we did was we compared the distribution of the lab tests of people who died, so this is the worst outcome, versus people who survived with the shortest length of stay, which we consider as the best outcome. And we figure out where is the overlap between these distributions and where do they separate, so that it's a better reference range now. When we see a lab test, does this translate into the worst outcome or does this translate into the best outcome? And it gives us a better perspective of how to interpret those lab tests in relation to the population that you are taking care of. So when we go around the world, we say that this is a good methodology to establish blood pressure cutoff for patients with hypertension. You cannot just adopt guidelines from the United States or from Western Europe, because you're not guaranteed that whatever is a good blood pressure here will also translate to the best blood pressure for your own population. And this can also be applied for the treatment of diabetes. Perhaps you would have a different target for blood sugar that would avoid or prevent complications from diabetes, such as heart attacks and strokes. Next slide, please. More recently, one of our publications made headlines. In this analysis, we reported that we did not find improvements in the last decades in the outcomes of patients with sepsis in hospitals that disproportionately care for more Blacks and Hispanics. We found a very good reduction in mortality among most hospitals when it comes to outcomes from sepsis, but we did not see that improvement in outcomes in hospitals that disproportionately would be admitting more Blacks and Hispanics. Next slide, please. Going back to the datathons before the pandemic hit, this transdisciplinarity model is increasingly endorsed by professional societies as a way to educate the next generation of clinicians in the field of data science. Next slide, please. But with all this excitement and hype around machine learning, or what we refer to as medical artificial intelligence, the technology may be on track to follow the missteps of the electronic health records. For the doctors among the audience, you know that everyone is frustrated with the electronic health record. Progress in machine learning has certainly outpaced its adoption in healthcare. For every tens of thousands of publications and conference proceedings on medical algorithms, only one or two are prospectively evaluated with clinical endpoints rather than model performance as outcomes. Next slide. The handful of trials that have been published, and we found only 4 so far, failed to demonstrate measurable improvement in population health. And 2 of the trials are here in this particular slide. Next slide, please. Sometimes with little input from providers at the front lines of care, data scientists are predicting disease trajectory and resource utilization, such as the one here on hospital readmission, that are clearly more heavily influenced by social determinants rather than vital sign measurements, laboratory test results, and radiologic images. For example, with readmission, what turns out to be most predictive of readmission is homelessness. And you don't really need a complicated machine learning model to tell you that. Every clinician would probably tell you that if you could solve homelessness, there will be less probability of the patient coming back to be readmitted within 30 days of discharge. Next slide. The other problem is that the machine learning community flocks to specialties where data sets exist. In radiology, ophthalmology, pathology, gastroenterology, and critical care medicine. Thousands of papers have been published on predicting or identifying patients with sepsis. And we would argue that this may not be the highest impact of machine learning. Where we need machine learning would be in specialties where there is a dearth of randomized controlled trials, such as pediatrics, OBGYN, surgery, and also primary care. We feel that these are potentially the areas where decision-making could really be improved with the use of medical algorithms. And now we ask, where are the COVID-19 clinical data sets? Next slide. There have been some that have been publicly released, but for the most part, they are what we call county level. So they just give you aggregated numbers, but doesn't really give you patient level data. This is one of them. This one comes from the New York Times. There's also a county level COVID-19 data coming from Johns Hopkins University. So basically they would tell you every day how many new cases are reported and how many deaths are reported per county that are ascribed to COVID-19. Next slide. There's a similar data set that has been released coming from France. And I believe more and more are becoming available from countries around the world. But the data is, for the most part, aggregated data. There is no patient level information. But they're still very useful, and I would give some explanation of where they can be used. Next slide. So this is just an example of a data visualization. It shows, as of a certain date, what is the county level COVID-19 cases per 10,000 population across the United States. But there is some limitation of this data. As you can imagine, the number of cases is so much dependent on the number of testing. So that states where they don't do a lot of testing, you may not find a lot of cases. So it needs to be adjusted for how many tests is being performed and then how random is the testing. Otherwise, this may not be a good measurement of the true incidence of COVID-19 across the different states. Our group is focusing on the number of deaths because the number of deaths really does not depend on the number of testing being done. But clearly the number of deaths is confounded by so many factors. I showed here a paper that was just released on Archive where they are proposing a process by which you could estimate the prevalence of COVID-19 in the community based on the number of deaths being reported. Next slide. So I mentioned that county level data is still very important in terms of allowing us to understand better how the virus behaves in the community, because here in the United States, we collect so many data at the county level. For example, the census data would tell you the age distribution, the gender distribution, the race distribution per county, and you could see how that affects the rate of rise, for example, in the number of deaths per county. There's also information about income distribution, burden of chronic disease such as diabetes, heart disease, lung disease, and county disease at the county level. Next slide. We also have information about the size of the household, which we know from studies in China affects the spread of COVID-19 in the community, and whether their jobs are in retail, in manufacturing, service, or healthcare, because I'm pretty sure that those will affect how the virus is being transmitted in the community. We also have county level environmental and all sorts of data collected by the cities available to us. Next slide. From pharmacies, you could get county level prevalence of comorbidities and use of medications. There are so many data sets out there that represent determinants and proxies of behavior. You can find out whether a certain county is primarily Democrat or Republican here in the United States. You can also look at news articles that are available to people for that county. And then social media posts could be an important proxy for the behavior of the constituents of a certain county. And then finally, there's location and mobility data. This type of data would come from cell phone towers. It would also come from GPS information collected by mobile phone apps. Next slide. This is just one of the data visualization that our group has put together, where we were able to compare whether counties that are Republicans or counties that are Democrats, whether they would have a steeper slope in the number of deaths from the time that they reported 100 deaths. And here you could see that the red states are all relatively higher in terms of the slope of death compared to the blue states. Next slide. What we found from looking at the location data that I mentioned earlier is that the effect of certain policies would be different based on your socioeconomic status. So in this New York Times article published last week, what they found is that people who belong to a higher socioeconomic status are more likely to be able to socially distance themselves. So here it says that social distancing could be a luxury for people who are well-to-do compared to people who are in the lower bracket of the socioeconomic status. Next slide, please. And as our gut intuition has suspected that there will be more health disparities that will be magnified as a result of this pandemic. And there are increasing reports now that the minority populations here in the United States are overwhelmingly dying from COVID-19 in cities in the United States. So here you could see some data visualization that counties where you have more Blacks and Hispanics would have a higher death rate from COVID-19. Next slide. So speaking more about this mobility data, this location data, back in December, there was a New York Times article describing a file from a location data company, one of dozens that are quietly collecting precise movements using software found on mobile phone apps. It holds more than, this particular data set that was featured in the New York Times holds more than 50 billion location pings from the phones of more than 12 million Americans as they move through several major cities. And this file represents just a small slice of what's collected and sold every day by this industry. Next slide. These are just some of the companies that have been selling this information even prior to the pandemic. Telecom giants such as Verizon and AT&T have been selling location data to third parties for years. And these companies justify their business on the basis of three claims. One, people consented to be tracked because they signed some data user agreement when they downloaded a certain app. And of course, no one reads those data user agreement. They also say that the data is anonymous, which of course is not true. You could easily identify a person from this data set if you know where they live or you know where they work, and that the data is secure, which is also questionable. As you could see, we were Zoom bombed earlier very easily because of problems with data security. Next slide, please. And indeed, from last week, we found that Google has already started looking at GPS information that they collect from Google Maps, and they're able to look at the adherence to social distancing across different countries, across different parts of a country. Next slide. In recent weeks, some of the most successful efforts to contain the epidemic were orchestrated by countries such as South Korea, Taiwan, and Singapore. And while surveillance through digital tracking has captured the headlines the most, we would say that the successes really should be ascribed to extensive testing, on honest reporting, and on the willing cooperation of a well-informed public. When people are told the scientific facts and when people trust public authorities to tell them these facts, citizens do the right thing even without the government watching over their shoulders. Next slide. And finally, for the last few slides, I wanted to highlight another key message. Ground truth in medicine is a moving target, even during a pandemic. The accuracy of findings, the accuracy of models is bound by space and time. And I would give you some examples. Next slide, please. A publication a few years ago showcased an algorithm that predicts acute kidney injury that was implemented at several Veterans Administration hospitals. And what the authors found is that within a few years, the model started over-predicting already, and the magnitude of over-prediction increased over time. This is what we call the model shift. And a good example of this model shift is the Google flu algorithm that was developed by Google around 2009, where they were looking at how people were searching for symptoms as able to predict the trajectory of the flu in the United States. And it even surpassed the accuracy of the Center for Disease Control. So in 2010, 2011, it was very accurate in its prediction. But by 2012, the accuracy was completely off. And it turned out that the people changed the way they were searching for terms on Google. And it really emphasizes the point that you need to be constantly monitoring the performance of a model, because there is no guarantee. In fact, you're guaranteed that the performance, the accuracy of a model would go down with time. Next slide. This is another good example of the lack of generalizability of models outside the original training cohort where the model was trained on. This is a presentation of a model that predicts whether a patient will develop a type of infection in the hospital called the C. difficile infection. It's considered a nosocomial or an iatrogenic complication, because the patients went to the hospital without this infection, and then they acquire this infection while they're in the hospital. And the authors here look at data coming from two very similar hospitals when it comes to patient demographics and when it comes to clinical practice. These are the Mass General Hospital in Boston and then University of Michigan Hospital in Ann Arbor. And they were surprised that the models that were developed to accurately predict C. difficile infection look very different across these two hospitals. There's not a lot of overlap between the features that predicted this infection the most. And it turns out that the prediction of this particular infection is so much dependent on clinical practice, and there was enough variation in the way patients are being cared for in these two hospitals that led to very different models. So the message there is you cannot buy an artificial intelligence algorithm that was developed in the United States and just apply it to another country, because there is no guarantee that the performance will be preserved. What you need to do at the very least is to measure first whether it's performing as well as it was sold, to using local data set. And again, you don't stop with implementation of the algorithm. You have to constantly be monitoring the accuracy, the sensitivity and specificity of that model. Next slide. This is a visualization of the genetic mutation of the SARS-CoV-2 over time. And as you could see, the virus has mutated as it spread around the world. It could explain why COVID-19 patients that we are seeing here in the United States are younger and healthier compared to those in China and Italy. The point is that in medicine, as I mentioned earlier, models and findings have half-lives. They have an expiration date. We need to constantly analyze data and reevaluate our knowledge of the disease. During this pandemic, our amulet is not PPE. Our amulet is not mass testing, digital technology, mechanical ventilation, hydroxychloroquine, or a vaccine. Our amulet is our ability to learn from the data. And next slide. I'm going to end with a quote from Yuval Harari. In order to defeat the virus, we need to share information globally. That's the big advantage of humans over viruses. A coronavirus in China and a coronavirus in the US cannot swap tips about how to infect humans. The Mimic database stands as a testament to the possibility of data sharing beyond the walls of Beth Israel Deaconess Hospital. Though our world has embraced data monetization, regulatory hurdles, and a publish or perish academic culture at the expense of open data sharing, our short-sightedness did not be our undoing. An unprecedented worldwide Black Swan event deserves an appropriate response, and this begins with an unprecedented joining of forces and data to best understand our foe. And with that, I have 8 minutes to answer questions. Thank you.
Thank you so much, Dr. Leo. And for me, it's really exciting lecture and eye-opening because we are not used to kind of learn about artificial intelligence and machine learning technologies in Palestine. And I'm sure the students have and the doctors have some questions. So if you have any question, please you can type in the chat bar, or you can just unmute yourself and ask your question.
Don't be shy.
Okay, I have a quick question for you before the students ask. So for those who have never, dealt with artificial intelligence and data science, could you please just give us a brief kind of definition of data science and the difference between, for example, artificial intelligence and machine learning?
Yes, so data science is not really that different from regression. I think most medical students and doctors in the audience are vaguely familiar with regression, where you create a formula, right? So you want to predict something, you want to predict death, and you come up with a formula so that if you combine the different features that you think would be predictive of death, it gives you a very accurate prediction of death. And we've seen this as illness severity scores. We've seen a pneumonia score where it would guide us in terms of whether someone with pneumonia can be treated as an outpatient or should be hospitalized or should be admitted to the intensive care unit. But for the most part, a lot of the scores have been developed just using expert opinion of some consultants. So you put them on a table and they say, I think this should be included in the formula. With machine learning, you don't rely on expert opinion, you rely on the data. So you perform regression, and regression is probably the oldest machine learning methodology that have been around really for about 300 or 400 years. But regression is very simplistic. It assumes that all the elements that you put on the left side of the formula are independently associated to the right side of the formula. It also assumes a monotonous relationship. But in reality, the different elements may be interacting in a complex manner so that you're not able to come up with a simple formula, A plus B plus C plus D would be some probability of death. With machine learning, there are far more complex ways of determining the relationship of the predictors with the outcome or with a classification. And some of examples of this methodology would be decision trees, which is the basis for random forest, for gradient boosting, or it could be a neural network. And neural network is really the basis for deep learning. So these are just fancy terms, and all you're trying to do is, can we come up with a way of relating a certain set of features with a label or a classification or a prediction? And that is indeed machine learning. So it does not, it relies less heavily on expert opinion or on an understanding of pathophysiology, but it's looking at how does the data relate with each other, and can we come up with some methodology so that if you apply this formula, you get a diagnosis or you get a prediction. So that is a very, very high level description of machine learning.
Mhm. Thank you so much. So we have a question. So Bashar is asking if is it possible to have COVID-19 deaths reported due to another cause? For example, like a patient got admitted due to COVID-19, but they developed, for example, MI or something like that. Can we rely on that to estimate, for example, the incidence of death, COVID-19 related death, and how can we overcome that?
Yeah, so that's a great question. And what we're doing now, so our team is working with ICU data coming from Italy, and we're wanting to build a mortality prediction model to tell us whether the patient is still going to be alive on day 14. But what we decided to do is we also do exactly the same thing using data from December and January. So in December and January, there was no COVID-19 in Italy. And then you compare the two models. So both models are looking at patients admitted for pneumonia, and both models are predicting death during their hospitalization. So now you have a baseline model that predicts death among patients with pneumonia. And now you have a model using data coming from February and March, where the majority of patients would have COVID-19. And you compare the two. So now you get a sense of how different is this pneumonia from the pneumonia prior to the pandemic. And basically what you're doing is you're looking for excess deaths that you could ascribe to COVID-19 by comparing it with a baseline model. So it's very important to know what the baseline death rate is. And you can really get a sense of what the excess death is if you could compare it to the baseline number. I have one more before I have to go.
Yeah, sure. So very quickly, Omar and Walad, they are asking almost the same question. So if they are interested in data science and artificial intelligence, what do you suggest to start learning about these fields? Like for a beginner, somebody.
Yes,
like
I would say go back to your statistics books and have a good understanding of regression, because I think regression is the basis for a lot of the machine learning methodologies. So neural network is nothing but a series of regression. So that would be my main suggestion.
Yeah, and actually we will have the next lecture will be with Aya and another kind of researcher who will be talking about regression. So please join us next lecture. And thank you so much, Dr. Leo, for joining us. And thank you so much for all the students. They are saying thank you in the chat box. I'm not sure if you can see them.
Yes, yes.
And
My pleasure.
thank you so much. Have a good day.